My team has been discussing the challenges of eCQM reporting from multiple EHRs and special concerns about deduplication. I think we understand the basics of matching and deduplication of patients. My question is the next step. Once you know that patient John Doe is on the two files and you have to get rid of one, how do you merge the data to capture the correct outcome on the eCQMs that you are reporting?
Great question, Gail. This may be fun. I've got a perverse set of fun. Apologize. It's more straightforward than it appears. It's really simply emulating at the organization level with multiple medical record systems what you'd see at the practice level with one medical record. It's a common occurrence that patients have multiple visits, multiple episodes, multiple measurements, multiple doctors, multiple practices, multiple opportunities to provide the indicated intervention. Well, we run into the same issue at different degrees of complexity with one provider with his or her one panel of patients in one EHR, but with multiple visits, or a group practice with multiple providers, patients seeing anyone there, one EHR, multiple visits, or when we step into the next level of organization into an ACO or a community healthcare system with multiple EHRs. And of course, we run into that need to report more often across an ACO than across just a garden variety community healthcare system. The starting point for any quality measurement project is to get a complete accounting of the patients and capture the data that generally indicates measure eligibility. For us, this is usually a complete set of insurance claims for the time period. It can come from the EHR, it can come from the practice management system. It's usually in both, and those systems are often combined anyway. The next hurdle is to get all of the relevant clinical data that indicates performance. Each piece of clinical data needs to include adequate patient identifiers to match it back to the eligible patients and a date stamp indicating when it was done. Notice I didn't mention that it needs to be tracked back to the practice or the provider. That's usually in it, and it's certainly not worthless data, but we don't care where it was generated if we have the data. The data itself and when it was generated give us all the information we typically need to decide which to use. Once we have all that relevant data normalized into a single data set, each piece tagged to the patient that pertains to when the data was done, we can then take the next step. In all cases, the measure specifications tell us which particular data element determines performance. Sometimes only the most recent data is factored into the analytics. Sometimes the best measurement from the time period gets factored in. If it occurred anywhere, anytime by anyone within the performance period, performance is met. So different ways this factors in, but once you have the data, we build the analytics on top of it to match the specifications and choose the right one. The great thing about this, and we've been experiencing this ever since Medicare introduced group practice reporting, it's now taken it to another level with ACO reporting. Every provider and practice gets performance credit when any provider and practice meets performance. There's kind of a halo effect there that everybody gets credit for the good work that collectively happens. So you should, as a community, end up getting better scores than any one of what you would as an individual practice. It means we need to have all of the data about all the potentially involved patients from all of the practice. Holes in the data, well, there's inevitably holes in the data. Holes in the data put holes in your performance measurement, that is, downgrade your performance, or both, or counts against your data completeness requirement. Now, again, missing data always means a lower score. If you don't know something's happened, then you can't get a good score for it. And now, if you actually don't know anything about the patient, that decrements your data completeness requirement. If you know you have the patient, and you have some data from some practices, but not the critical data from where the intervention occurred, then you're missing performance data. But again, it's always chosen. We want all the data, and then we choose the appropriate performance meeting data element from that set. So we never individually choose the data to include. We never discard or disregard data. When there are multiple data points, each potentially meriting a different performance score, the measure specifications always tell us which one takes precedence. Great question. Thanks.